It's a landmark day in India today with the rollout of Corbevax, a made-in-India vaccine for children between the age of 12 and 14. Corbevax, which is priced at 145 rupees plus taxes to the government, is perhaps the cheapest COVID vaccine in the world. Biological E is headed by one of India's most remarkable business leaders, Mahima Datla, the MD of the company. At 44, she heads a company which has probably inoculated 1 in every 2 babies in India. Now, Biological E is the first private sector biological products company in India. It represents really some of the finest in Indian pharma, where we are clearly world leaders, certainly in manufacture. Mahima Datla joins us now. Thanks, Mahima, very much for being with us. It is very much a landmark day. We've been trying to speak now for the better part of 1 year, but I think you've been waiting for all this time, perhaps for this day. What is this day the culmination of for yourself and for your company?
Thanks so much for the opportunity to speak with you. And I must say, we've always sort of believed our actions should speak louder than our words. So I apologize that it's taken us so long to come on air and speak with you. Of course, this day has been an extremely emotional one for myself, our entire team, because we've had such a history of supplying pediatric vaccines, and to finally join this fight against COVID to help our country, and that too it being deployed for children down to the age of 12 has been an overwhelming feeling. And we're just, humbled to be part of the solution.
Give us an idea of the battle or the challenge that you faced in scaling up, because what you all along have said and what BioE stands for is that you didn't want to be the first out with a vaccine if you didn't have it in numbers. But that in itself is problematic, because to scale up is not easy. Tell us how difficult scaling up was.
Sure. So there were 3 considerations for us. One, I'm sorry,
Go ahead.
Am I audible?
Yes, you are.
Yeah. So there were 3 considerations really. The first one was obviously that we get a vaccine that works. The second one was really safety. So we wanted to use a tried and tested technology, because we wanted to make sure we're not introducing more variables into a vaccine when the virus itself provides us with enough challenges. And the third was affordability. And this point is directly related to scale. If we aren't able to scale the vaccines, vaccines involve a huge amount of fixed costs. The nature of the business is such that you have to invest in, whether it's a facility or trained manpower or power, all of it, majority of it is fixed costs. So if you can imagine, if you're allocating those fixed costs to fewer number of doses, obviously the cost of the product is very high. So we've always made product in upwards of 100 million doses, keeping in mind the birth cohort, not just of our country, but to the markets we service. So we've always thought about, capacity in terms of scale, but never before have we been challenged to think about scale as 10 times more than what we've ever done in the past.
Right.
But that really meant, because we needed to keep affordability at the center of this, because I've been in numerous occasions where, country governments and health budgets are stressed with resources and creating the fiscal space given the large number of priorities before them. So we felt it was our responsibility to make this as affordable. So we chose a technology that was really scalable. We make hepatitis B vaccines using the same technology. So we were able to really demonstrate scale, and what that allowed us to do was lower the cost of the
So Mahima, just so that I understand it, it's 145 rupees to the government, and with taxes, how much does it come to?
With taxes, maybe about 10 rupees more, but in the private market, I can tell you the breakup. It's 800 rupees that we would be supplying, and then if you add the excise duty and then the administration costs, the total would come to about 990.
Now, and in the case of what you're providing to the government of India, it's the cheapest vaccine in the world, right? COVID vaccine?
I'd like to use the word most affordable.
The most cost effective.
Correct. That's absolutely right. And just by our supplies, just through our supplies of 30 crore doses, we'll be saving the exchequer close to 1,500 crores.
And when you do export it, have you decided on the price at which you're going to export it?
We haven't determined the final price. It will be a little bit higher than the government because we were very clear that, we wanted the Indian government to have the best possible price. It would be slightly higher, but I think much lower than some of the vaccines that they're currently using. The price really will be determined based on three things. One is the volume, because we really can't, given the scale we've invested in, it'll be really challenging for us to respond to small volumes with the best. I think the second will be really the terms as well, because we really need to secure supplies in advance for the kind of scale that we're producing. So if our deal structures entail, favorable terms, then that will play into the price as well. Sure. But we would attempt to make it the most affordable, because we want this to be sustainable for countries to continue immunizing their people.
How effective is it against Omicron?
So it's a very difficult question to answer. As you know, our head-to-head comparison we had done with Covishield, and this was during the Delta wave. So the extensive evaluation we've done against the original ancestral strain as well as the Delta strain, Omicron really became an issue after we completed the clinical trials. Yeah. And then it took a good 4 to 5 weeks, even for academic institutes, to come up with the right construct, the pseudoviruses that you can challenge with the new strains. So we have some very preliminary data that suggests our vaccine behaves in a fashion that confers some cross protection, because we had actually tested it even against the beta variant, which was sort of in between.
So what does the preliminary data show, Mahima? How effective percentage-wise against Omicron?
Well, it's hard to determine percentages because it wasn't a statistical model and we don't have sufficient data to corroborate anything in terms of percentages. Like I can tell you it was close to 90% for the original strain, 80% for Delta, but we don't have the statistical models to suggest this. But what I can tell you is that, of course, there is a drop in antibody titers, but in naive subjects that weren't exposed to the virus, we saw very high immune response. This was for 30-odd subjects. So bear in mind, this is kind of post-hoc analysis, but as and when data becomes available, we will present it to the appropriate scientific bodies as well.
And so, Mahima, what are you doing to get that data on the efficacy of this drug against Omicron? Because that's what worries us now, and it's our variants as well.
So I think all companies have been trying to, test their vaccines to look at how does it perform against Omicron. The key is if you have clinical sera samples available from your early trials, then you can perform the neutralization assays, which really in kind of my layman terms is the simplistic way to explain it is to show how much protection or cross protection you will get, or how much ability does your vaccine have to neutralize against the virus. So we use neutralization assays as a good correlate to show how much coverage there is. So companies are in the process of doing this. Everybody anticipates there will be a drop in protection, but if the protection level still remains high, I think we would still have sufficient coverage. What we do know and what the scientific community seems to converge on is the higher the antibodies, the better chances of preventing severe disease, preventing hospitalization. We've seen this across the world. So the key is, are we conferring sufficiently high antibodies? And that should translate to lower incidence of serious events.
So therefore, again, it is a question of time, because this statistic is important, particularly when so many companies say we offer 90%, we offer 80% effectiveness. Are you looking for a statistically robust number before you can actually come out with data which suggests that, look, we are X% efficacious against Omicron?
I'm not sure that's very practical to do. I was saying earlier in the day, when you even think about efficacy, all of the vaccines were licensed based on efficacy against the original ancestral strain.
Right.
We all know that efficacy didn't translate to the exact same efficacy. There was a change when it came even to the Delta. We know there will be a change when it comes to Omicron. So I think we cannot define efficacy in classic terms like that anymore. And the second fact is that by the time we try to determine this statistically, we're already seeing other variants emerge. So we're not sure how relevant it will be to kind of go after that. I think it's important that we do kind of the quick analysis that we can around neutralizing antibodies as best as we can with whatever information different companies have and publish that. Knowing fully well that there won't be a statistical basis for it, but it'll still give us some insight. It'll give us a direction into what the kind of protection levels look like.
Which really brings me to my next question, peer reviews. That's so important, particularly in terms of international recognition. Where do you stand, Mahima, with peer reviews, for example, Lancet or other journals?
Yeah, so I anticipated this because I'm hearing a lot of noise around this. So I did make this distinction, and I think it's important to recognize that there's two things, right? Is information publicly available? One. And then is information being presented, peer-reviewed, and published, which is second. So for the first one, I have to really clarify to everybody out there that our information is available, the clinical data is available on our website. It's also part of the pack insert. In fact, this is a requirement that we upload all this information. So it's publicly available for everybody to, process it, critique it, appreciate it, and so on. With respect to publication, we recently published our phase 1-2 data, but it's taking us some time to ensure that the internal review process takes place because we've had several partners engaged in the development of this program, including government institutes like TSHTI. We've had Baylor College of Medicine, obviously. We've had, Dynavax, the supplier of the key adjuvants, and we want to make sure it's reviewed by them. So, I think within the next week to 10 days, our pivotal information will be published, and following that, the pediatric, simply because this data came 1-2 months apart.
Where would it be published, most likely?
So we're making it available on an open database because for the Lancets of the world to review it and then take it up for publication, they have their own internal process. And as you can imagine, they are inundated with publications, both related to developments in the mRNA space, tools that we're learning new information on a daily basis. So we can't anticipate what those timelines will be, but once we put it on that open publication database, then, it follows its process. But I do want to clarify our pivotal study where we did a head-to-head comparison against Covishield is made public. It's available on our website, and all that information is also in our pack insert.
Okay. What about World Health Organization clearance, Mahima? Because, for example, as we've seen in the past, people traveling from country to country, they are still considered in many cases unvaccinated if it's not recognized by the EU regulator or the World Health Organization. And the WHO, let's face it, takes a whole lot of time to work through things. So have you approached them?
Yes, we have approached them, and one of the prerequisites for them accepting the application is that you receive license in the country that you first register, which we only did in December. So shortly after that, we confirmed our intent, but WHO was aware of the developments. So they are currently reviewing our application, number one. But I also have to say that, we've had a lot of experience. We have 7 pre-qualified vaccines. And yes, in some cases, it took longer than others. But by and large, we've had a very positive experience with WHO in terms of reviewing our data, and so much so that we had a pre-qualification, post-COVID as well, which goes to speak that, they really take these very seriously. And I think they're committed to making sure that they can help in whatever way they can to make vaccines much more accessible, particularly in other parts of the world.
Mahima, there's an article which has appeared in The Wire which suggests that the National Technical Advisory Group, or NTAGI, didn't necessarily clear this vaccine. It may have been cleared by other bodies, and they're quoting Dr. Jayaprakash Mulial. What is the clarity on this?
Yeah, I really haven't spoken to him personally, but I can confirm that we have shared our data with NTAGI every step of the way. So usually the process is that our first point of call, or the first people we share data with is obviously the drug controller, who convenes a special group of experts to review data. And it's not just to review data, to even provide input on protocols even before we conduct clinical studies. So we receive an approval for that, and then post conducting, they review the data before they confer approval. So our practice has always been that we receive approval and then we approach NTAGI and present data, which we consistently did throughout this process. On some occasions, we were solicited by NTAGI to present data, even if it was, part of the trials, because they want to just be kept informed. So I'm at a loss to see where this was coming from, but I can confirm that NTAGI has consistently reviewed our data. So I would.
And they've cleared the data.
I'm not aware of a formal process of clearance, because that's an internal process which they recommend to the government, but the only formal process of clearance for a manufacturer is the license that they receive, and subsequently it's policy advice that's given, which is really an intra-government discussion.
Well, we were speaking there about NTAGI, or the National Technical Advisory Group on Immunization, absolutely nodal organization when it comes to the rollout of vaccines. Joining us now, Dr. N.K. Arora, who is the vaccine panel chief. Thanks very much, sir, for being with us. We'll come to you in a moment, but first a couple of comments. Parangav writes, is it safe for children, or are we in a hurry to just vaccinate the maximum population? Riddhi has a comment, and he says all eyes are on this vaccine that is being made in India after the centre placed an advanced order for 30 crore doses. Well, we're joined now by Dr. Arora. Sir, thanks very much for being with us. There was that article by The Wire, and I asked Mahima Datla, and I think you saw that as well, on whether NTAGI had actually cleared Corbevax. Has it been cleared entirely by Corbevax prior to its release?
So I thank you very much. So pleasure talking to you. And I had the opportunity while you were talking with Mahima, and so that was good to know what she said. So I must say 2 or 3 things.
Yeah.
One is that we have reviewed the Corbevax data several times. When it was animal studies, at several forums, many of us have been looking at the data when they were animal studies, then phase 1, phase 2, and most recently we have looked at the pediatric data also, along with adult data. So data has been reviewed. The response to antigens, the antibody response to the vaccine is very good. In children, it is more than adults. The third thing is, as compared to the comparator vaccine, the antibody response is better with Corbevax. And another issue is that this vaccine is the adverse events, even those all are mild, and that swelling or local pain is also much less as compared to its comparator vaccine. So it's a very safe vaccine, and as it was discussed, we have another protein subunit vaccine which is being used for over 4 decades.
Yep.
And that is hepatitis B vaccine. It's the same vaccine, same platform, but and a similar structure. And even newborns get that vaccine.
Right.
So this is the history of vaccines manufactured on this platform are there for a long time, and they are very safe. Even the adjuvant which is used is also very safe. There is no problem.
Right.
And then finally, you mentioned about the issue of vaccinating children. So before that, I would like to say one is safety, the other is immunogenicity.
Yeah.
The efficacy today, as Mahima was telling us, that in today's environment, you cannot have efficacy trial because it becomes unethical to have a large number of people with one dose or second dose, so it becomes difficult. So WHO has also accepted that we will have vaccination, these immunogenicity studies and safety studies, and that is what has been done.
No, but
Now,
Dr. Arora, I'm just trying to understand, and you are very much the expert on this. When a Pfizer or a Moderna or any group actually comes out and says, look, we are 90% efficacious, we are X% efficacious, and we don't have that data for the reasons which you have spelled out, or Mahima has spelled out, doesn't it become problematic for users to actually know how effective the drug is?
So first of all, we must understand what does 90% mean, or 80% mean, or 95% mean. I think we should understand that.
It's against the old strain, the original virus, the original strain, right?
No. There is the protection is at 3 levels, and we must understand that. One is protection against new infection, protection against symptomatic infection,
right,
and protection against severe disease. So
right.
3 types of efficacy is there. All vaccine manufacturers project their efficacy against symptomatic disease.
Right.
It does not tell us about prevention of infection, because most of the times it is less than 50%.
But we don't
30,
even
40.
have that over here on symptomatic disease, sir.
No, just. The second is for the mild disease is there, and then the severe disease. Now, at the moment, whatever data is available, these are bridging studies, and you can just do immunogenicity. And the antibody response is seen as a proxy of the efficacy of the data. We know that how much severe disease it will prevent, or how much symptomatic disease it will prevent. You cannot say with the current, any of the clinical trials which are being done today. Another few vaccines are going to come.
No, but now, sir, now that Omicron is the dominant strain, it's hardly relevant for any of us to know how effective any vaccine would have been to, you know, the original Wuhan strain or the Delta strain, etc., etc. So therefore, will we ever be in a position where there is robust statistical data to show how effective this is in all of the different categories that you mentioned?
So I will digress a little bit, and I will tell you today evening's information.
Yes.
In Hong Kong, there is an outbreak of COVID. A large number of COVID infections are taking place, and deaths are taking place. And 75% are those who have not been vaccinated, and these are elder people. And whatever vaccine they are using the Chinese vaccine, Sinovac, or some of the other Chinese vaccine they have been using, and it does not help them in none of the vaccines. We are also aware that even Pfizer vaccine recipients who have received the booster dose, they have also been getting 2 boosters, even then they have been getting.
No, but,
so
but Dr. Arora, if you say this, then, you know, people watching this program would be wondering, then what's the point of vaccines at this
No,
stage,
yes, but that is what I am coming to.
Infection?
That is what, Som, I am coming to, that none of the vaccines prevent infection. Practically none of the vaccines, maximum 30-40%, they prevent the infection. And Omicron is a variant which basically was recognized as a vaccine escapee or a breakthrough infection, even in South Africa and all over the world.
Yes.
Now, the whole important thing is, what is the benefit of vaccination? Yes. And benefit of the vaccination is that anybody who has received 2 doses of the vaccine, risk of severe disease, risk of hospitalization, and risk of death becomes less than, it protects 97-98% in all these conditions.
So, Dr. Arora, I must ask you one more question. Now, you know, the government of India's booster policy, and we've done at least 5 to 6 interviews on this. Many people would have said, now even the WHO says that, look, let's have boosters out. Your argument has always been, we need to ensure that most Indians, all Indians, eligible Indians, get 2 doses. Now, we are approaching that, right? We are almost there. So why haven't you rolled out boosters as yet, sir?
Yeah. So in fact, you know that today every individual above the age of 60 years is now getting a precaution dose or a booster dose, whatever we may call that. Because initially we thought comorbid individuals may benefit, but it is difficult to get the individuals comorbid. So this is now to all the people above the age of 60 years, everything. So that is first step, because there are 11 crore people who will require precaution dose in that. But it will be spread over next 6 months or so. So the decision regarding other age groups, we are collating data as well as about the vaccines, whether we should use homologous, which is being used at the moment, or heterologous. So we have plenty of vaccines now, plenty of doses, and the studies are on that which vaccine and which heterologous combination or homologous combination is going to be the best. Right. So that is being thought about, but pediatric is also important because children with comorbidity have to be protected. Sure. And that's why 12 to 14 years children are being given, because to identify comorbid children is a challenge. Absolutely. They are 10 to 15%, and therefore a blanket immunization for all children 12 to 14.
No, and it's the best thing, sir. Children need to be in school. That's where they belong, and they need to be as far protected as possible. I suspect we are going to revisit this conversation in a few months, but I'm going to ask you again, Dr. Arora, why have you not yet rolled out boosters? But perhaps you'll have something to the contrary to indicate at that stage. Thank you, sir, as always, for being with us.
Pleasure. Thank you.